Hi, I'm Dr. Scott Worden, the TOS guy. Today we're live streaming from downtown Sunnyvale, California, not far from the Apple campus and the Google campus, in fact. Today we have some beautiful Indian summer. I hope you all are doing well out there. The topic of today's short talk is 5 additional frequently asked questions that we receive here at Vanguard Specialty Imaging. So let's go to question number 1. Is the trapezius imaged during the Neo Vista examination for TOS? So, as you may know if you've done any reading on TOS, the trapezius muscle is a rather large muscle. There's one on each side of the spine. They're triangularly shaped with their apex attached to the shoulder blade or the scapula on each side. But there's a significant portion that runs up the back of the neck and attaches on the back of the neck, a portion that attaches to the shoulder blade on each side, and the rest of it goes significantly down the thoracic spine. Classically, the trapezius is described as having 3 major components. The part that starts at the neck pulls the shoulder blades upwards. The part that attaches to the shoulder blade pulls them medially towards the midline. And the part that's on the thoracic spine can stabilize them, pull the shoulder blades toward the midline, and also pull them down towards the ground. These muscles are superficial. You can feel them by putting your fingers on the skin. They often get injured in the same types of mechanisms that injure thoracic outlet syndrome patients, like motor vehicle accidents and falls. They can get overused, as in people who use their computers too much for work. When these muscles get out of balance, they will certainly affect the position of the neck and of the shoulder blades. And as you know, if you've been a regular viewer of our talks, or if you read our website, that malpositioning of the shoulder blades is likely a major contributor to patients with TOS. Now, we do image these muscles. We look for asymmetry side to side. We look to see if the muscles are bigger or smaller than normal, or sometimes when there's nerve damage, you can see that there's some fat involving the muscle rather than pure muscle. So yes, we do look at these muscles. We also measure the positions of the shoulder blades in 6 different dimensions. So if one of the trapezius muscles is not working well, or even if both are not working, we can measure that and see how much of a difference in the position of the shoulder blade on each side we find. The second question I'm going to answer actually, is a good one. Why does Dr. Worden bring up the history of TOS so often? Well, I'm fascinated in the history of medicine in general. We've done a talk before on how appendicitis, or even the existence of the appendix, was questioned for hundreds of years, and how this sort of paradigm of questioning and emotions over intellect and eventual research and fact and publication and spreading the word and raising awareness modified our understanding of appendicitis. Nobody really cares about the appendix until it's inflamed. And for many, many, many years, people didn't even believe that humans had an appendix. And then when they convinced eventually enough medical authorities the appendix existed, people wouldn't believe that there was inflammatory disease arising in this structure. Finally, those barriers were overcome and surgeons started treating patients. And nowadays, we have very successful diagnosis and treatment of the appendix. In addition, one of the tools that we use to diagnose appendicitis is a CAT scan. CAT scans were around for decades before anybody really used them to look at the appendix. But once we did use that tool, we saw that the diagnosis of appendicitis and the ruling out of appendicitis was much more successful. Now, we believe the same thing with thoracic outlet syndrome. So when I look back at the history of TOS, including it was first discovered and described in 1818, that's 200 plus years ago, and we look at some of the luminary names in medicine that researched TOS, very, very credible people who added to our knowledge base. There's scatterings of papers from not so well-known people, but eventually over time, we got more of an idea of what's going on until the late 1980s, early 1990s, when the disputed TOS arose. And without going into the history of that in great detail, it really set us back a bit, because now a bunch of doctors just said, well, heck, if it's disputed, I'm not going to bother examining for it or diagnosing it or, God forbid, treating it. So I love these paradigms. They reflect how science is one thing and scientists are really another thing because they're human. So we all want to be careful with that. There's lots of research coming out now on TOS because awareness has increased. I've gotten to work with some really neat people around the country, and these people are bringing up new ideas, progressive approaches, and I think we're on the doorstep of making real progress with the disease. So don't be complacent. Remember, from history, it's taught us that we can think ahead, we can experiment, but we need to keep an open mind. The next question that's brought to our attention is, has your thinking on EMG and TOS changed at all? So EMG and nerve conduction velocity, what we call electrophysiologic studies, EPS, have been used to study and diagnose and confirm, let's say, neuropathies around the body. But different neuropathies have different challenges to them. So some peripheral nerves are very superficially located, like the median nerve is located in the carpal tunnel at the wrist. And if you turn your wrist over and you look at the palm side of your wrist, there's a tunnel there, what we call a fibroosseous tunnel across the wrist. And there's a bunch of tendons and the median nerve that go through this tunnel. Now, at this point, it's a small peripheral nerve. It has a few motor components and a few sensory components. And you can examine it with EPS, electrophysiologic studies, relatively easily. And so it's very good for carpal tunnel syndrome and looking at this small endpoint of the median nerve. But as you march back up the arm, what you end up with is a brachial plexus that's involved in TOS, is big cluster of nerves. There's motor nerves, and there's sensory nerves, and there's the autonomic nerves. And it's branching, a multiple branching system that's different in every patient. And there are large nerves with thousands of nerve fibers in them. On top of that, it's not so superficial. It's buried deep in the neck where you can't get access to it easily. So trying to study that cluster becomes like looking at a license plate from outer space. I know the CIA is supposed to have satellites that can see a license plate from 200 miles away. And that's maybe the example of the carpal tunnel syndrome and the median nerve. But then you move to the surface of the moon and you're looking at the screws on the license plate. And now it's even harder to figure out what's going on. So remember that there are technical limitations, and EPS, EMG often is the name people will use, can very frequently be negative in patients who are very symptomatic. There are a number of technical reasons. We've done a previous talk on this. I urge you to look it up and watch that. It was a short talk, but I explained why EMG fails in most cases of TOS. Also, some people have used EMG to rule in other diseases like cubital tunnel syndrome, where the ulnar nerve is impinged upon at the elbow. Well, remember that there's something called multiple crush. If you have compression or tension on the brachial plexus, you can have an apparent ulnar nerve entrapment at the cubital tunnel, but in fact, it's really occurring more proximally. So have my views changed? There is one study that people use a little bit more now called the MAC study, or MABC, medial antebrachial cutaneous nerve. This is a small nerve, sensory only. It comes off the medial trunk of the brachial plexus. It arises from the C8 and T1 nerve roots only. And by the time it gets to the medial part of the forearm, it's a pretty simple nerve. That may be an indicator that's used by EMG or nerve conduction studies to diagnose TOS. But even if you do diagnose it, you have no idea of the anatomy of where these nerves are being involved. So imaging tests are still a vital contributor. Our next question, why do I get headaches with TOS? Well, a lot of patients get headaches with TOS because they have to deal with their insurance companies. And I don't mean to be smart about it. It does happen to people. Well, let's talk a little bit about headaches and TOS. The headache is split into many different types. And I'm not a neurologist, and I didn't stay at a Holiday Inn Express last night. But there are types of headaches that we believe are more associated with TOS. Number one, there's an occipital headache, or a headache that's in the back of the skull. If these muscles are tight, the muscles that hold up the neck and skull, like after a long day at work frequently, those muscles can go into spasm and they can create a pretty severe headache. In addition, there's sheets of tissue called fascia that run alongside the muscles. And those fascia have small holes in them to transmit nerves, like the very small occipital nerves. If that sheet of fascia is pulled tight down in the neck and chest because of TOS, or because of abnormal posture of the neck and head, then those small holes can malalign and they can pinch the occipital nerves and create pain in that area. In addition, we know that in many patients with neurogenic TOS, they have a component of venous congestion where the veins don't drain properly from the arms or from the head and neck. And we believe that that venous congestion allows the brain to be a little too full of fluid. The pressure is too much to drain easily, and those can cause headaches as well. So there's a couple of reasons why we do see headaches frequently with TOS. Bear in mind, headaches are common in many other diseases as well, and it may be coincidental that you have TOS and headaches. But headaches is a contributing symptom, and no patient should be ruled out from having TOS because they have headaches. Now let's go on to our final question. I had a negative ultrasound. Can I still have TOS? Now, ultrasound is a very valuable tool for a lot of reasons. If you're looking at blood vessels like the arteries, you can move the arms into many positions and watch the live blood flow going through the arteries. It's fascinating. You can actually hear the swishing sound and you can watch the waves go up and down. The veins can be compressed as well, and you can watch a different type of waveform in the veins get affected when you move your arms. And unlike an MRI, patients can be examined with their arms in front of them, by their sides, across their chest, over their head, essentially any position. And the patient can be sitting or lying down. So in those respects, ultrasound can be very helpful. And in addition, if your doc wants to do a selective block of the anterior scalene muscle or the pec minor muscle, that your doc can do that. He or she can see the structures very well and the needle under ultrasound and inject the medicine at just the right spot. Now, what ultrasound can't do is it can't see through bones or through lung. So when you get to the top of the chest and the collarbone gets close to the first rib, it's pretty hard to see whether those nerves are being compressed between the collarbone and the rib, the costoclavicular interval. And that's an important spot for looking for TOS. It happens in many patients with TOS. So ultrasound's limited there. In addition, for all the variants, we know that the nerves go through the scalene muscles or around them the wrong direction. Oftentimes, it's hard to see the smaller components of the brachial plexus nearly as well as an MRI can. So if ultrasound is negative, it doesn't tell you you don't have neurogenic TOS. It may tell you your blood vessels are not compressed. But let's remember, arterial TOS is very rare, and venous TOS is pretty uncommon. For venous TOS, classically, there's a blood clot. Ultrasound's great for that. But for neurogenic TOS, compression of the artery or compression of the vein does not equal compression or tension on the brachial plexus. So MRI is better for that purpose. So we've answered our 5 questions, and I would like to have a few of our participant questions come up. Bugged 120. Hi, Scott. Do you consult with international TOS patients looking for a diagnosis? At present, no, but we are working on it. There's a number of administrative and insurance reasons. We want to make sure we're in the right before we do that. Check back with us in about 2 weeks through tosmri.com, and we'll be glad to clarify that for you. Thank you for the question. Yes, and I'm being reminded here that Dr. Art Jenkins does consult with international patients, and we're happy to connect you with him. If you don't get this number, just reach out to us at our website. Hi, Gigi. Dr. Werden, my doctors have attempted to reach you to assist with my rare case of TOS. 4 hospital systems have not seen my type of TOS. There's compression in my scapula. It's compressing veins and nerves. All right. So yes, my assistant Jenny is glad to take your information, and we do consults with people who live in most of the states in this country. We can give you the ins and outs of that, but we're glad to set up a consultation with you and give you an idea of what the next test should be or who the next TOS specialist you might want to see is. Again, through our website, tosmri.com. Hi, Vladislav. Hi, Scott. What do you think about the human spring mass model regarding TOS? I'm going to pass on that for a while. It's written by a chiropractor out of Chicago. I'm just going to pass for now because I haven't studied it in enough detail to offer a healthy critique. All right. So it's a book you can buy on Amazon if you look for it. Again, written by a chiropractor out of Chicago. Thank you for the question. Daniel Sloop. My wife had an angiogram but I do not believe the doctor was doing anything you are describing right now. She exhibits multiple symptoms of TOS, and what would you recommend her next step to be? Thanks for the question, Daniel. First thing is, we're not offering specific medical advice here. We always say that, but we want to be careful for all of your privacy. In general, angiograms imply that we're looking at the arteries. Some people will use them to describe looking at the veins, but in general, angiogram or arteriogram should be reserved for tests looking at the arteries, and venograms would be for looking at the veins. Now, I've mentioned before that Alfred Adson, a very famous neurosurgeon at the Mayo Clinic in the 1920s, he developed Adson's test. And this is a test where he manipulates the forearm, or your doctor will manipulate your forearm while they hold onto your wrist and they keep a hold of your radial pulse. And then they'll position your neck in a certain way and have you take a deep breath in, and they'll see whether the pulse disappears. Adson did this because in the 1920s, he didn't have MRI or CT or ultrasound, and he had a very clever test here. He reasoned that if the artery was compressed, that the brachial plexus was likely to be compressed as well, because they're very close together, particularly in the costoclavicular interval between the rib and the collarbone. Now, with the advantage of all the testing that we have, I can tell you that the artery and the nerves do not get compressed at the same time. We see many cases of severe compression of the brachial plexus without compression of the artery. We see examples of both being compressed. We see rarely, but with some frequency, compression of the artery without compression of the plexus. So Adson's test isn't great for this for the same reason. An arteriogram looking for arterial compression is not great for the reasons I just mentioned. If you have a normal arteriogram, but you're not looking at the brachial plexus, that brachial plexus may be compressed or stretched, or it may take an abnormal course. The arteriogram does not rule that out, and particularly if it wasn't done with the arms overhead to stress the system, so to speak, like a cardiac stress test you get on a treadmill, push your heart to work a little harder. Well, the same thing with TOS. We put the arms over the head to see how narrow we can make those spaces and if they do compress or stretch brachial plexus. So, Daniel, if you and your wife reach out to us, we can do a consultation. We can help you understand what tests have been done by looking at the reports, and we can then advise you as to how to move on with next steps that might help rule in or rule out TOS. And thank you for the question. There we go. I just see now. For more context, she had arterial clotting in her left arm 2 years ago, and doctors have had no explanations. Again, without specific medical advice, the general idea would be to find out where the clotting occurred. Was it a thrombus, meaning a clot occurring right at a spot of arterial aneurysm, let's say? Or was it emboli, where pieces of blood clot broke off and went distal to arteries down the arm? There are a lot of reasons for arterial clotting in different arteries in the body. They occur for different reasons. What you'd want to know in general would be if a blood clot did form up in the thoracic outlet, you'd want to do a test like mine to understand what is damaging the artery, okay? Because the artery by itself doesn't get damaged. It had to have something happen to it. And if it's because you're getting narrowing between bones or around ligaments, then you want to treat that cause and not just treating the blood clot in the artery. So please reach out to us. Thanks, Daniel. Gigi, thanks. She left Jenny a message. Jenny will get back to you, Gigi. Statin Angel. I have 7 weeks post-op and I still have a lot of scapular pain. What causes the scapular pain? I had a first rib resection and no pectoralis minor release. Okay, again, just a heads up, nothing too specific. After surgery with TOS in general, patients can have pain for a number of reasons. First of all, any surgery that disrupts the body will cause pain. I've had some recently myself, and your doc gives you pain meds. Secondly, there can be issues after surgery in any type of surgery, like a seroma or a collection of fluid that just seeps in. There can be a hematoma or a blood clot. In particular, for TOS, patients can have a small leak of air around the lung, called a pneumothorax. If the surgery was on the left side, there can be a lymphoceal leakage of lymph, which is a special drainage fluid that empties into this. Sorry, it's on the right side, the right subclavian vein. You can have pain because the nerves are inflamed or swollen from being manipulated. Um, and there's a number of smaller reasons, but this is something that your surgeon should be addressing, not just giving you pain meds, but figuring out what caused the pain. And we do often post-operative MRIs to look at people who have had surgery but still have the pain. Was there an adequate removal of the right first rib? Are there any of these fluid collections or post-operative changes? Is the brachial plexus inflamed? And those different answers will give us a different approach as to what the next steps are. This would be a perfect case where we could consult with you and get a look at your surgical records and see what's happened since your surgery. In particular, scapular pain, depending on the approach that your surgeon took and which muscles they had to divide to get to the right spot, you might have muscles that control the position of the scapula that are not balanced correctly. Either they're too loose or they're too tight or they're injured. So it's a multifactorial issue, not one that I can address here for privacy reasons or with just a little information. We need more detailed information. So thank you and reach out to us. Hey, Daniel, of course. Thank you. Samantha, hi. Hi, Dr. Werden. Do you know of an MRI or other imaging that can account for an axillary vein return issue when the arm is down while sitting or standing following TOS surgery? So that's a good question. We have very rarely had patients come to us with TOS-like symptoms, but that are worse with their arms down rather than their arms up. And we've scanned these patients. Obviously, they've been sent to us for scanning. We scan them to look for something unusual. There's many variants in the human body, and sometimes there can be a variant, like an extra band. There's an axillary band of Langerhans. It's very rare. We've seen it occasionally, and that can press on blood vessels and the brachial plexus or the nerves of the brachial plexus. This is one where you might want to do an ultrasound, because if it's venous return, meaning I'm guessing that the arm may be discolored like a bluish purple, or it may be swollen, larger than the other arm. Sometimes this is because the veins won't allow that low pressure blood in the veins to return back to the chest easily. It could be damage to the vein itself. Sometimes people have had a catheter put in the vein through the elbow to provide a chemotherapy or other medicine to their heart, something called a PICC line, P-I-C-C. And sometimes that can cause a blood clot to form. Sometimes also from a blood clot or from other damage like previous TOS, the vein can be left with a scar or a stricture where it's narrowed. And that will never resolve no matter how much blood clot you take away, until surgically or through the skin, somebody goes in and gets rid of that stricture or narrowing. So you might need a venogram depending on where the blood slowing down was found to exist. So it is possible to do a CT venogram or a regular venogram with X-ray or an MR venogram. Ultrasound may help pinpoint where the narrowing is occurring. Again, you guys are asking such good questions, but you're bringing in detailed cases that we would need more information on to really be able to point you in the right direction. So I hope that sounds somewhat familiar, Samantha. Again, if you reach out to us, we'll certainly do our best to help you in your specific case. And thanks for your question. We want to remind everybody something I haven't done. You got to mash that like button. Please subscribe. And next to subscribe, there should be a little bell you can hit, which will mean that we will automatically have you sent an alert when we're going to do a new presentation. So hit the like button, hit subscribe, and hit that bell, and it helps us move higher in the rankings so we can get more awareness of TOS out there. Do we have further questions? Gigi says, Samantha, that's what's happening to me. I'm not getting the return. We're glad to connect people if they want to connect, but I can't do that online. All right. Well, everybody, thank you for participating. We greatly appreciate it. Again, we all want to raise awareness of TOS. We want to help each and every one of you individually with your issues. So reach out to us through tosmri.com. We'll tell you the details of our consultation process and our scan. And in the meantime, visit our website, follow us on Instagram, follow us. We're on TikTok now, YouTube like this. Again, subscribe, hit the bell button, and give us a like. Everybody, this is Dr. Scott Worden, the TOS guy. We appreciate you, and we'll see you soon.